It's really my pleasure to be here today, and I'm really looking forward to speaking to each of you and learning and really to learn more about digital. We've started this journey with a survey out to each of you, and we want to share back those results to you. Walter introduced me, so I'll just go through quickly what we're going to cover today. So today we'll give you a sense of who the project team is and how we came at this, sort of where does this study situate in a broader context of other studies. I'll spend most of my time talking about the evolution of digital practices, and what we're really going to focus on is what was proposed and approved, and then what's happening at least up until the point of earlier this year. And so we'll look at that both within and across OHTs. And really the intention here is we want to engage. We want to engage in a dialogue. Walter alluded to this earlier. And so what we want to know is we want to hear from you as we present our findings. We're really looking to contextualize what we're finding. And if you have insights, we'd love to hear them in the chat or through any questions. And in the end, you also hear from us a little bit of a plug where we're going to be looking to learn more from you. So we'll be refielding the survey, hopefully early next year in the winter 2024. And we want to gain a bit more data, particularly for those younger OHTs. So that'll be a little bit of a theme that you'll hear as I present my results. So without further ado, here's the team. Here's the team that's looking at this. So you know a bit about me. My partners on this are Dr. Angela Aristidou, who's a digital fellow at Stanford's Human-Centered AI Institute. And she's also an assistant professor at the School of Management at University College London, where I also hold a fellowship. And together, we're really management scholars in this space. So we look at things from a management perspective. And so you'll hear us talk a lot about practices, and we'll talk a lot about organization. I'll preface this by saying we're not public policy scholars, we're not medical scholars. So we're really looking at this from an organization and from a management perspective to understand how these practices diffuse across OHTs. Walter is, of course, our partner in this study as well as the principal investigator for HSPN. And he really gives us the insight of OHTs on the ground that we use, and we help to contextualize our findings. So where did this particular study of digital come about? So if we take a step back, this is really part of a global study on cross-sector collaborations in the healthcare sector. And the study is really in 3 countries, Canada, the UK, and the US. And I can speak mostly to the Canadian side of things as the lead of that arm of the study. And where we initially focus is in Ontario, and particularly with Ontario health teams. And a sister study to the one that I'll present today, focused on this notion of practices and activities, and I'll define that in a moment, but activities that OHTs were doing more broadly. And so what we're looking for is we looked at the transfer of activities between OHTs, some of the best practices that we found, and this wasn't just digital, it was everything. And we were encouraged by this idea that we saw OHTs innovating on the ground, developing practices that really suited local needs for their local populations. And we thought this was an encouraging sign where OHTs were almost filling in some of the gaps that were almost too broad for the province as a whole. So there was some element of this that was intriguing. But when we took a step back and we looked at this study a little more specifically, there was this curious consistency in the digital activities that were proposed. So the basis of that data was really the applications that were proposed and approved by OHTs directly and approved by the ministry, but digital activities largely looked the same. And we thought this was a little curious, especially given the fact that OHTs had been approved prior to and after the pandemic, which is quite a disruptive event, and we thought digital would be impacted quite a bit. So our point of investigation started there, and we thought, let's look into digital a little bit further to understand what maybe is going on after proposal and into implementation. As we studied this, we took into consideration what the objectives were for digital broadly. What you see on the screen now are the objectives that are in the digital health playbook that many in Ontario would have received. And so there were 3 key objectives: offer patient-centered care, create more connections between providers, and be able to manage the system a little bit better through some analytics and some population health measures that could improve healthcare across the province more broadly. we kept these in mind as we began to collect data. And so then we went out and looked for data. And where we started were, at the time that we began this, we were looking at the first 3 cohorts of OHTs. So if you look at a timeline, we began all the way back to October 2019, which seems like ages ago now. And what we did was we made a choice to launch our survey to all the OHTs that were active as of September 2021. And we launched the survey, particularly if you look at the far right, in October 2022, and it was open until February to March 2023, or earlier this year. What that left us was 3 cohorts that we could analyze. We had cohort 1, 29 OHTs that were in existence or active for between 2 and 3 years at the time of the survey. We had cohort 2 of 13 OHTs they were active for about 2 years, and cohort 3 that were active for a little more than 1 year. And so what we wanted to do here was have an ability to compare across time, where there was different times that had elapsed, and we could use this differentiation in time to be able to understand how time maybe impacts implementation in OHTs. And we asked a very simple question. We said, how have the digital practices evolved from the point of approval to the point of implementation? And so we kept this in our mind and began to design our study. And so as we designed, we started with this idea that we wanted to get a better understanding of what OHTs were proposing to do. So we looked at the applications, and we used the applications to extract what we call activities. And on the next slide, I'll define specifically what we mean by an activity, but we began by just pulling those out of the applications. What did the OHT say they were going to do when you began and when you received approval, and you were planning how the OHT would function? We went through a validation step. So we used some computational techniques to validate how those activities might relate to one another. And again, I'll give you a little bit more about how this actually happens. And then, of course, we did the survey. And so we use those activities as a way to field the survey. So I'll dig into each of those sort of piece by piece, just to let you know, how did we actually get the data behind the study that I'll present to you. So I mentioned we start with an activity. In management, we define an activity largely as a set of actions. Or in this case, in this particular study, what did an OHT propose to do to implement a digital technology? And so these are sort of the on-the-ground activities. And what we did was we targeted the applications, looked at specific questions where digital was being asked, and we qualitatively extracted them out, and we kept the sentences or the paragraphs as verbatim descriptions, exactly as they were worded by the applicants for the OHTs. And then we coded these by hand and said, which activities are common and relate to one another. And we had groups of activities as a result. When we went through this, we ended up with approximately 14 activities per OHT, with some differences across cohorts. So in cohort 1, there were about 15 activities for digital specifically, and in cohorts 2 and 3, approximately 9. Some of these can be attributed to the differences in applications for OHTs, and we know that cohort 1 had a slightly different application compared to cohorts 2 and 3. But remember that what we're comparing is OHT to OHT, right? So what was proposed, and then for those same sets of practices, what was ultimately implemented and how. So then we start to, and I'll come back to this notion of practices, but we start to look for commonalities. And we used a language algorithm, because we had verbatim statements, to determine commonalities. So if language was similar, it would group into topics. And that was another clue to validate what we had coded by hand to say, yes, these activities belong together. We then took those activities, went back out to the field. We created customized surveys for each of the OHTs, and we asked them roughly 3 questions. For each activity, was it implemented as planned? Was it changed? And if so, why? Or was it not implemented? And if so, why? I mentioned when we surveyed the OHTs, what we received back were 21 responses from cohort 1, a pretty robust sample there, and about 5 responses from the OHTs in cohorts 2 and 3. And this is sort of me coming back to this notion of what we would really love to learn more from are these OHTs that have been active for a little less time, and that will really help us substantiate these findings a little bit more. Nevertheless, we'll present what we have from the cohort 1 and cohorts 2 and 3 OHTs with some implications for the differences between them. But that will be one theme that we'll talk through as we go forward. So one point is back to practices. I mentioned practices before. What you can do is you can think of practices as a set of activities. There are reasons why we want to do this. For one, if you think about verbatim activities like those 2 on the screen, which are real activities proposed, there's a huge variation between OHTs and which activities are proposed because they're quite specific to the OHT as a whole. It makes it quite difficult for comparison. So one technique that we use in management is to code these activities as a set of practices, common activities that relate to one another that create almost a bundle of activities. So when I say practice, I'm referring to a bundle of activities. What we would do is we'd look just like we do on the screen with these 2 activities, and we'd code these and say, expanding access to information through my chart or giving patients access to personal health information. These sound like patient data access. We do this by hand, and then we do this with an algorithm to say these words are related to one another when we look across all of the activities, and we ended up coding almost 2,600 activities. So it can be quite a task for a researcher to code these. So the computational algorithm helps us validate, and we can have some confidence that these are indeed related to one another. So we did this for all of our activities, and what we ended up with were 4 practices. 4 practices are on the screen. They were reflected as patient data access, partner data sharing, virtual care, and data planning. Now, what gave us some confidence is these mapped actually quite well back onto the 3 objectives that were in the digital playbook, with one exception where we split out patient data access and virtual care because these seem to be different practices from the data that we had. And so what we're going to analyze in much of the results are these 4 practices and the differences in how they were implemented. Roughly, I'll share 3 sort of core findings. First is when we compare across cohorts and we look at all the digital practices, we tend to see that cohort 1 largely implement their activities as planned compared to later cohorts. Again, we have more data there. We would love to learn more on this. We also do see later cohorts with some particular challenges that connect digital practices with some health equity challenges. So we'll talk through that a little bit. As we saw in the poll, partner data sharing certainly presents the largest ongoing implementation challenge for OHTs. So I'll talk a little bit about that in the second section. And in the third section, we do think there are examples of OHTs where partner data sharing can foster learning. There are some OHTs that seem to be able to implement this well, and that has ripple effects across digital specifically that can benefit integration as a whole. So we'll share those findings as well. So I'll start with the first finding, which is the comparison between cohorts. And I've classified these as initial results. Again, we want to hear more from those younger OHTs to be able to substantiate these to a larger degree. And if we just look at what was implemented versus what was not implemented, here's what we see. The green bar is what was implemented as planned. Blue is what was changed, and orange is what was not implemented. And there is a large difference between cohort 1 and cohorts 2 and 3 in terms of implementation as planned and not implemented. Now here, initially, before we actually saw any of these results, we were actually quite surprised to see this. It's a bit of a puzzle for us, and we're trying to substantiate this further. And the reason being was cohort 1, their applications were approved prior to arguably the largest shock we've seen in the healthcare system in a long period of time, which is the pandemic. And so having the ability to sustain and implement what was proposed, despite having gone through that shock about 6 months after approval, we were quite intrigued by and still are investigating and are slightly puzzled by. If there are thoughts in the chat and as to intuitions as to why, perhaps from OHTs directly, we would love to hear them. And so this is quite broad across all digital practices, but we felt digital would be quite largely impacted in cohort 1 that didn't appear to materialize. And that could be a possible, maybe it's a good news story. Perhaps there's something more behind here, but more than 50% of the practices implemented as planned from those applications. Now, we do have some indication as to what might be happening here. And so when we look at the reasons why, and I'll explain the table at the bottom as a second. So we're going to zoom in on virtual care, which is where we have most of our data across the cohorts. So the practice that we'll analyze is virtual care. The first column, the middle column you see there is the reasons for change. We're bolded as sort of a categorization of a reason for change. And the far right column is the reasons for not implementing something. Interestingly here, all cohorts have similar issues as reasons for changing activities. And most of the time, it comes back to what we've labeled as economizing. And this could be something in virtual care specifically, whereby you initiate a virtual care platform, you launch it, and it had several, say, bells and whistles associated with it. And when you went to implementation, you realized you didn't need all of those features. So it was either feature rich or perhaps too expensive. And there were some changes along the way that reflect some level of adaptability that OHTs were sort of economizing on, but still implementing. They're just modifying slightly. So we see some consistency. Now, what we also see is there's a greater implementation rate in cohort 1 compared to cohorts 2 and 3, despite having the same reasons. So here's where we think there's learning transfer opportunity number 1. Perhaps there's things that could be learned from OHTs that have gone through similar experiences with virtual care specifically that can be transferred along to cohorts 2 and 3. And again, any learnings here, any success stories, those we think we could potentially identify, and we would love to hear more directly from you. Now, differences emerge in terms of why virtual care was not implemented or why digital was not implemented at all compared to what was changed. What we tend to see as reasons for not implementation relate to far more complex issues. And so one reason that emerged was issues related to health equity. And here what we heard was credible and reliable access to internet or cellular data, where naturally digital activities and particularly virtual care rely on internet access and cellular access, particularly for remote communities. This was a stated reason that came back from the later cohorts as to why virtual care was not implemented. And that's a unique challenge. And in some ways, that challenge is broader than OHTs directly. So trying to do virtual becomes a little more challenging. That reason emerged far more in later cohorts than earlier cohorts. There were other reasons related to compartmentalized expertise. If Francophone expertise was in one partner organization, but perhaps wasn't in the primary care element of virtual care, then it became difficult to implement virtual care for particular populations. That was true for privacy regulation as well. So some reasons come through. Again, we would love to learn more about some of the implementation challenges here. And so early learnings, there's consistency in what gets changed. So there's some adaptability happening here, and we think there's a learning transfer opportunity from early cohorts to later cohorts that we could leverage to a greater degree. And there's also these larger health equity elements showing up. And I can see a little bit in the chat as well, that there's some elements particularly for rural OHTs that are difficult to implement when it comes to digital specifically. And that's where we wanted to put a spotlight on that to highlight that as an implementation challenge that may be beyond the scope of OHTs themselves and what can be delivered. So these are the learnings from the first group of OHTs, and we'll transition to the practices themselves. So back to those 4 practices. And the ones we talked about: patient data access, partner data sharing, virtual care, and data planning. Where we have the data is in cohort 1, so we focused here. And so many of the findings for the remainder of the presentation will focus on those OHTs that have been in existence for greater than 2 years or between 2 and 3 years from the point at which they answered the survey. What we found was across the 4 practices, there were not many differences in terms of practices being changed. Where the largest differences emerged, and consistent with the poll that we just saw, was that practices differed in how they were implemented or whether they were not implemented at all. let me rephrase that, whether they were implemented at all or whether they were not implemented. And that appeared to show up mostly in partner data sharing and that particular practice. And so the results, if we take out the change element, and what you see here is green represents the practice implemented as planned, orange represents not implemented. And here you can see almost a reflection of what came back from that poll. Partner data sharing implemented as planned less than 40% of the time, whereas the other three practices implemented over 50% of the time. We can say there's enough data here that the difference is statistical and we're confident that it's different, and the audience effectively validated that for us today. Now, it's not that this is particularly surprising. I think we could all reason that partner data sharing itself is the most challenging of all of these practices to implement. And so we can still dig into the rationale provided by the OHTs because there are some nuggets in here that, again, we think can foster some learning. So if we dig into the rationale as to why and we provide some results, again, I'll explain the table and describe what you're seeing on the screen. Across the columns, there are the practices. I've taken out digital planning for expositional purposes and focused in on patient data access, partner data sharing, and virtual care. The first row are the activities under the practices that were implemented. The second row is what was not implemented. And then the rationale as to why is in the bottom. So if we look at patient data access specifically, what was implemented were self-management tools such as MyChart, Clinical Connect. These types of tools were implemented. There was approximately one activity implemented on average per OHT. What was not implemented were broader web portals or apps. These tended to be at a provincial level. And the rationale here was some of these were simply deferred to other institutions, particularly Ontario Health was mentioned in this case. So there was some rationale here in terms of who was accountable for this implementation, which is why it maybe wasn't implemented. If we go over to the right-hand column, when we look at virtual care, what was implemented was virtual visit access, online booking. These tools were implemented. On average, about 3 activities were implemented. What wasn't implemented were expansions to this, such as expanding into home care or expanding into other providers, such as mental health institutions. And the rationale provided was managerial capacity. So this could have been financial capacity. This could have been a focus on other priorities. But it was mainly a prioritization element. Primary care was the initial focus, or online booking was an initial focus. And some of these other elements were still on the plan, but perhaps will be implemented a little bit later. When we look in the middle column, partner data sharing, where most of the challenges tend to be reflected, what we see is some OHTs implemented common platforms. They were labeled as clinical information systems. And on average, about half an activity was implemented. So most OHTs in this case, or there were many OHTs that didn't implement any partner data sharing activities. What was not implemented were the same types of activities. So we have commonality between what gets implemented and what doesn't get implemented across OHTs. And some of the rationale provided was scaling complexity or a lack of guidance. Here is where we think there's some potential for some of that guidance, at least, to come from within the OHT community themselves. And perhaps there's some learning and that can occur between OHTs depending on context. Of course, there are different contexts and different things happening at a local level, but there's some learning where OHTs have been successful in some implementations of partner data sharing that may be beneficial for other OHTs to learn from as well. And so what we tend to see as key learning here are partner data sharing certainly represents the largest challenges, but there are some OHTs that have had success with implementation using similar types of activities to other OHTs. So there may perhaps be, we believe there's an opportunity for some learning to be shared across the OHT community here. What does this all mean here? And is there a way for us to qualify an amount of effectiveness related to these practices? So if there are struggles with implementation, is there anything that we can learn from here? And here is where we'd love to engage in some discussion. And so I can see a very active chat. And so that's fantastic. We'd love to hear more, particularly on this conversation of effectiveness. And what we're looking to learn from really is how you would measure and define effectiveness of digital implementations. I'll tell you how we classified it. Some of these themes emerged in the chat. Now, we did this qualitatively through the survey, and we asked again the OHT digital leads, and our definition was related mostly to integration. So what we asked about was improving patient handoffs, specifically the ability, and we came back to this notion from the original OHT guidance document that this was about navigating patients through the system. And so we asked the question in that respect. And qualitatively, we did this from a scale, 5-point scale, where 1 was very ineffective to 5 was very effective. Now, what we learned when we asked this, and we asked this for each activity that was implemented or changed, because you can't really evaluate something that was never implemented. We focused on only those that were implemented or changed. And so we had the strongest perceived effectiveness in patient handoffs for OHTs that implement partner data sharing. And what we were encouraged by was we see spillover effects for OHTs that implement partner data sharing to other digital practices. Put differently, for those OHTs that do implement partner data sharing, it has a halo effect across digital more broadly and likely spills over to other practices not related to digital as a whole. And so this is at least for our definition of effectiveness in improving patient handoffs. Looking at the raw scores, effectiveness of practice implementation for all practices on our scale of patient handoff effectiveness was about 3.6 out of 5, where 5 is very effective. And we see differences across each of the practices where partner data sharing is highest at 4 when implemented. Virtual care is the lowest at 3.4, and that we do think there's enough there to say it's different than the other 3. There's something going on there. And so we took our learning from the previous section on partner data sharing and decided to split our data based on those OHTs that implemented partner data sharing versus those that did not. And we'll share those results now. So what you see in our measure of effectiveness, the green bars represent 6 OHTs that largely implemented almost all of the proposed partner data sharing activities. We had 5 OHTs, and again, these are cohort 1 OHTs, that largely did not implement the practices that were proposed. And we compared the two and the scores across both. And what we see is systematically higher scores across the board, and particularly improvements in virtual care. And this is the spillover effect that I was referring to before. When OHTs implement partner data sharing practices, it does seem to impact the effectiveness across other OHTs. Now, I'll add a little caveat here on data that I did not show you. You'll notice that there are 10 OHTs that did respond to the survey that are missing. Those OHTs didn't propose any partner data sharing activity, so there's no implementation proportion that we could show, but we can evaluate their practices, and those do look a lot like the orange bars. And so whether it's proposed or not implemented seems to have similar effects on effectiveness, at least as surveyed by the OHT digital leads, compared to the OHTs that have implemented partner data sharing practices. So we do think there's some benefits here and some learning that could take place across the system, and that's going to be our segue to the next conversation, really. So those OHTs that do implement partner data sharing report higher across the board effectiveness ratings. Virtual care increases by the largest margin, but we do see increases across the board. And if we were to sort of sit back and hypothesize a bit as to why this might be, I think I've seen some of these comments in the chat already, but having data across partners, especially in virtual care where there could be more of a clinical focus, you can imagine that those clinical visits just might be of a higher quality with access to more patient information from more partners. And so the benefits may be revealing themselves there, although this is some area that we would love to dig into further and understand more, particularly from those in the field, in terms of why that might be the case. So in summary, we think there's some learning opportunities across time. Cohort 1 can potentially streamline implementation of digital activities for later cohorts, younger cohorts that have been active for less time. The health equity focus has come up multiple times. We do see that in the data as well, and we think there should be a spotlight on that and how that does impact digital implementation, particularly virtual care. And as we've talked about, discussed, and polled, partner data sharing certainly is a challenge. There are some examples in the system that we could potentially learn from, and perhaps some of those successful implementations are leading to effectiveness, at least as we've measured them and defined them.